All right. Hello, everyone. I hope you guys are doing well. So my name is Alp. I am a first-year medical student here at UAB. So just 20-minute walk away. I live right here. So today I'm going to be talking about facelifts and how they're reported, the variability in reporting of surgical facelifts. So I'm sure all of us are at least somewhat familiar with facelift operations. They've been going on for decades. Now, the current field is focused mostly on this mass system, and it's tightening these muscles so that people have improvement in their beautification and they feel more confident. So what we found through reading papers is that generally we found that it's very difficult to compare papers because the report outcomes vary greatly. The no two papers we've generally found are listing the same outcomes. But we wanted to see the extent to which this is the case. Are there some variables that are reported more often, and what variables are neglected more often? So the aim of this study is to quantify the disparity in reporting of outcomes and to see the extent of the problem. So this was a systematic review of all types of surgical facelifts. Now, we did exclude thread lifts, and then we started out with approximately 900 papers, and then we narrowed that down to 52 papers. So this was a systematic review, and then we looked at what outcomes are reported, and then we listed them out and saying that this paper listed this outcome, and then we use descriptive statistic to summarize the findings. All right, so this is the crux of the paper right here. So we found that, so I will quickly explain. So the green at the top is the variables that are reported most commonly. So things such as age, gender, hematoma, follow-up time, nerve injury. They're reported more than 75% of the time. So this is very good. So this allows for a high degree of comparability. However, as you go down the list, there are still very important variables that are not reported as often. And some of these I think are very surprising because in other fields, they tend to be very important, right? So for instance, smoking is only reported 42% of the time. So we don't know, in many papers, we don't know if the patients are previous smokers or not. And you might wonder, what does this look like? So I want to draw your attention to these images right here. So all of the white spaces are piece of missing information. These are all missing information that we don't have, and this is preventing us from comparing surgical outcomes, and therefore it makes it very difficult for surgeons to decide what operation is best for their patient. Because again, a lot of these papers are in small groups of patients that a single surgeon sees, and it's a method that the surgeon has developed on their own. So if another surgeon wants to adopt this method or integrate it into their practice, they need to learn how the patient population and the outcomes of that paper compare to their own patient population. But with all of this missing data, it is going to be very difficult for them to do so. And so we basically just found that a lot of important information is missing from these papers. And again, it's not just smoking. Again, there's a lot of other complications or important demographic information. For example, race, BMI, hypertension, diabetes, seromas, they're all reported less than 50% of the time. And I'm assuming that most of us know that we want to know this information going into surgeries, and we want to know how we should adapt our surgical procedures to reflect our patient population. So considering that we found there to be many inconsistencies in reporting outcomes, what is the next step, right? Because we've clearly identified there is a problem. So the next step is to work with surgeons and hospitals across the Southeast, and then eventually at a broader scale to create guidelines for publishing surgical outcomes. So there's many papers out there. There's many surgeons doing great work and creating new methods that improve the field every day. Even though they focus on the SMAS system, these improvements are very critical for progressing the field and very helpful for certain groups of patients. But we want to make sure that there is integration and there is a standardization of reporting outcomes so that other surgeons who want to integrate these methods can do so. And we also want to make sure that we highlight outcomes and variables that are not frequently published, so that if we were to create a database of sorts, then we can make sure that they're included and that surgeons are making sure they include that in their papers. So do you have any questions? Anyone?
Like outcome to reporting?
Yeah, so that's a very good question. Thank you. So these were restricted within the past 10 years. So the dates were all similar, right? A lot of these were very recent papers, and that wasn't really there was not really any improvement, to be frank. I think that a lot of doctors report the outcomes they see and the risk factors they see, but if they failed to report on the ones that they may not immediately notice, and that makes the comparison difficult, and that hasn't really changed with time, I would say. And what was your second question?
Second question, did you look at a different journal?
Yeah, well, to be frank with you, we didn't necessarily quantify it by journal, and that is probably a good next step. But again, we're very broad with our search. Again, we started with 900 papers, right? And so again, we reduced down to 52, but we found this to be a problem in not just one or two papers. And I should emphasize that. I should go back. So one point that I failed to mention is no two studies had report the same outcomes, right? When they were not homogeneous. Even in the best papers, there were still variability, and we don't want that. So I understand that they have a higher process of choosing what papers, a higher criteria, but even then, there are inconsistencies, and we want to eliminate that. Any other questions? Right. So this is, going to be involving first a regional and hopefully then broader collaboration between big institutions. Again, we want to, we have plastic surgeons all around the Southeast. We want to bring people together, and we want to create a consortium of people to discuss what variables we want to know. Again, some of these are not as important as other variables, and we want to highlight, okay, these are the 10 or the 15 variables that we need to make sure that we have a good, we can have a good operation. And once we decide on those variables, then we would, publish guidelines. We would hopefully start a database of sorts, so that there's increased integration between different institutions, different surgeons. So does that answer your question? Or again, like at this point, this is just highlighting the problem. This is not necessarily saying this is the next step is going to involve collaboration between different people.
All right. Thank you so much. Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.